Good morning, everybody. Well, I have the greatest pleasure this morning to introduce a friend, a colleague, and somebody I'm just really proud to be able to make this introduction about. It's Dr. Lisa Newman, who will be presenting today at our Frontiers in Oncology. Dr. Newman is a surgical oncologist with a practice dedicated to breast cancer management. In 2018, she was appointed to oversee the breast program at Weill Cornell Medicine at New York Presbyterian Hospital Network, where she serves Manhattan, Queens, and the Brooklyn sites. And previously, she was in Detroit at the Henry Ford Health System, where she served as the breast program director, covering multiple hospitals throughout Michigan since 2015. And before that, she was the director of the breast program in Michigan. And she is, so let me just give a little bit of personal background because Dr. Newman holds a master's degree in public health from Harvard University, where she also obtained her undergraduate degree. But Dr. Newman, I met her when she was at MD Anderson, where she was doing her surgical oncology residency, and she finished that in 1997 and decided that she wanted to get her master's degree in public health. And so she came to me because I was doing some research in breast cancer, and she was really interested in validating the Gale model in African American women. And she came to me and she said, Melissa, I'm going to go to Harvard. I got accepted into the Harvard program, and I need a project, and I would really like for you to be my mentor. So I was like ecstatic because I just, thought the world of Lisa, and I thought this was such a great opportunity to be able to do that. And so we searched and searched, and we actually were working with Mitch Gale, and we searched and we found an incredible data set, which was the CARE study. And we worked with Leslie Bernstein, and Lisa found a project, and we were able to validate the Gale model. And Lisa published that, and we were co-authors on that paper. But we've been friends. We've worked together on other projects, and we've been friends and colleagues. And I guess I can say that I was her mentor, and I can put her on all of my tables as being Lisa's mentor. And I'm really, it's a real pleasure and honor to say that. But Lisa and I have continued to follow each other's careers and be friends and personal friends, and it's really been an honor to say that I am able to do that. So Dr. Newman's primary research is focused on race, ethnicity related to variations in breast cancer risk and outcome in the evaluation and management of high-risk patients. She's broadened her applications to neoadjuvant chemotherapy and special surgical techniques such as skin-sparing mastectomy and lymphatic mapping, sentinel lymph node biopsy, and her extensive research related to disparities in breast cancer risk and outcome has been published in numerous peer-reviewed medical journals. She was featured in CNN's documentary, Black in America 2, and she's been featured in Breast Cancer Medical Expert for NBC's Today Show, as well as CBS Nightly News, and she maintains a very active community service record. She currently serves as the Chief National Medical Officer for the Sisters Network and the African American Breast Cancer Survivor Support Group. She oversees an international breast cancer research and training program involving a network of physicians and facilities in Ghana, Ethiopia, Nigeria, Uganda, Mexico, and the Caribbean. And the program has focused on triple-negative breast cancer in women with African ancestry. Her work has been acknowledged with several awards: the Top Blacks in Healthcare in 2018, Phenomenal African American Women of 2018, Esteemed Women of Michigan in 2018, Healthcare Hero in 2017 and 2012, and I can keep going, but this year at AACR, she was the Victoria's Secret awardee, and that was an incredible award that she received, and we were really, she's a rock star, and I can't tell you how many awards that Lisa has, and she is so well deserving of every single one. And I could go on and on. She serves on the scientific advisory board for the Susan Komen. She has served on numerous committees. I actually aren't, I think you're on the NCAB, or we at least serve together on, because I know I'm on the, because I know we serve on, I'm on the BSA and she serves on the National Cancer Institute, NCAB. She's on the so many different boards and surgical boards, and has done so many things. And Lisa's career continues to be just exploding, and I'm just so happy for her to be here, and I wish that she was here in person, because it would be so much fun to hang out with her and to do some fun things together. So let's put your slide back up, and I want you to get started, because I don't want to take any more of your time from your presentation. Lisa, thank you so much for being here. I'm just really happy to have you here.
Thank you, Melissa. It's one of my greatest sources of pride to be able to say that I was mentored by you. You've mentored so many, because you're just light years ahead of everybody. And so even though we are contemporaries in terms of age, you absolutely were one of my most honored role models. And you've mentored many who are substantially older than you, because you are just such a source of wisdom and phenomenal guidance. So thank you very much. Even though we're on opposite coasts right now, every time we run into each other, whether it's in person or via Zoom, it just feels like we never left each other's side when we were sharing the same faculty at MD Anderson. So it's just delightful to see you again. And thank you for that very generous introduction. So I will be talking to you guys today about some of the work that I've had the pleasure of being involved with, looking at the association between germline, the genetics of African ancestry, and risk of triple negative breast cancer. And hopefully by the end of my presentation, you'll see why our team calls this area of research oncologic anthropology. Get the slides to advance. Okay. The World Health Organization defines social determinants of health as conditions in which people are born, grow, live, work, age, as well as a broader set of forces that shape daily life conditions. And I don't think anybody would argue with the fact that poverty is indeed an incredibly powerful determinant of adverse health. And as shown by this slide, poverty is significantly higher in our communities of color, most notably African Americans and Hispanic Latinx communities. Going hand in hand with the higher poverty rates are other socioeconomic disadvantages, such as being uninsured or being unemployed, with both of these socioeconomic disadvantages also being disproportionately present in the communities of color, African Americans and Hispanic Americans. And so it's not surprising that both of these population subsets suffer disproportionately from adverse health conditions such as obesity, hypertension, and uncontrolled hypertension. And of course, these comorbidities contributed to the higher COVID mortality rates that we saw among communities of color. But there is a unique history behind the social determinants of health and the systemic racism that afflicts the African American community, dating back to the era of slavery. And even though slavery was abolished 150 years ago, its sequelae persist in a number of different ways. Residential racial segregation is one of the things that remains with us. And residential racial segregation was supported by our government through discriminatory banking practices that were legal several decades ago, including redlining, where African American neighborhoods were literally zoned out of opportunities for financing and mortgage lending, so that these neighborhoods essentially led to families that were trapped in communities featuring the nutritional insecurity and food deserts, poorer public school system, which of course has an impact on reduced employment prospects, And all of these features go hand in hand with healthcare access barriers. And there are also much denser populations in these neighborhoods, which played out in the recent COVID pandemic. And so it's also not surprising that when it comes to the specific diagnosis of breast cancer, that this cascade of socioeconomic disadvantages afflicting African American families over many, many generations will result in poorer outcomes from breast cancer because of delays in diagnosis with a more advanced stage distribution, and ultimately resulting in the higher mortality rates that we see from breast cancer in African Americans compared to white Americans. Furthermore, there's a whole other body of research looking at how the mere collective experiences of discrimination and living in poverty can affect the stress hormones and the cortisol system. And this area is called allostatic load, where the collective experiences of living in discrimination will lead to poorer outcomes from cancer. And so it's therefore very legitimate to ask the question that we frequently hear here in the United States of whether race is actually a genetic or biologic entity or at all, or is it simply a socio-political construct? Now, the answer, of course, is that racial identity is both. Racial identity is definitely a socio-political construct, and how we self-identify, as well as how society labels us, definitely has an impact on how we live, where we live, and how we access healthcare. However, racial identity is also associated with some germline ancestral genetic factors that can also contribute to cancer burden. And we've actually known for several decades that when it comes to a diagnosis of breast cancer, that factors aside from socioeconomics also contribute to outcomes. And this table is simply one evidence of that. This is taken from a study that I conducted with my colleagues at the Harvard School of Public Health more than a decade ago, where we simply conducted a meta-analysis pulling together all of the studies in the literature looking at breast cancer survival rates after accounting for some measure of socioeconomic status. And as you can see, adjusting for socioeconomic status in these more than 13,000 Black breast cancer patients compared to more than 75,000 white breast cancer patients, we still see a statistically significant, nearly 30% higher mortality hazard for the Black patients. Furthermore, there are several features that characterize the breast cancer burden of African Americans that really can't be easily ascribed to socioeconomics exclusively, such as the younger age distribution. And up to 40% of Black breast cancer patients are diagnosed under the age of 50, compared to only 1/5 of white American patients being diagnosed in this premenopausal age range. We also have a higher risk of adverse tumor features, such as the high-grade tumors, ER-negative, and triple-negative breast cancers in Black women compared to white women. And there's a higher population-based incidence of primary inflammatory breast cancer in African American women. Lastly, there's the very poorly understood higher population-based incidence of male breast cancer in the African American community. So we really do have an obligation to evaluate the genetics and tumor biologic reasons that might be accounting for all of these differences. You might appropriately assume that looking at clinical trials data would be a near perfect way to disentangle socioeconomic status from racial ethnic identity, because the very tightly regulated clinical trials mechanism should be such that it's not possible for discriminatory healthcare practices or socioeconomics to have an impact on treatment and outcomes. And so this was the motivation for a terrific study conducted by Kathy Albane and colleagues, where they pulled together a whole series of Southwest Oncology Group adjuvant therapy trials for a variety of different cancers. And they wanted to answer the question of whether equal treatments delivered in the context of a clinical trial would result in equal outcomes regardless of racial ethnic identity. And happily, they did see that the clinical trial participation equalized outcomes, except when it came to the hormonally driven cancers. And for the breast and prostate cancer adjuvant therapy trials, African Americans continued to have statistically significant poorer outcomes. So many of us that have dedicated our careers to disparities studies were very excited that Kathy's work would usher in a whole younger generation of investigators interested in looking at genetics and biology contributors to breast cancer disparities. And we were therefore a little dismayed that Time.com called her study an example of racial profiling in medical research. We were happy that her work did generate a lot of publicity that was appropriate, but to call it an example of racial profiling was really, I thought, a disservice, because of course, racial profiling is something that does need to be condemned when we talk about its presence in the criminal justice system. An example of how racial profiling, so to speak, in cancer is so very important is shown here, where we see that characterizing the racial ethnic identity of our patients is a critical epidemiologic tool. And we absolutely have to look at all of the features that characterize our patients when we are trying to determine why some patients have a better or a worse outcome than others. Now, looking at this slide graphic on the left, we see that population-based incidence rates of breast cancer historically were lower for Black women compared to white women. But when they changed over time, they changed in parallel, suggesting comparable environmental influences on breast cancer incidence. The lower two curves on that graphic, however, show that the population-based mortality rates from breast cancer were actually equal for Black women and white women until we reached the early 1980s. And at that point, the curves separate primarily because of declining death rates in white women, but largely unchanging breast cancer mortality rates in Black women. And this is probably because we started to unmask differences in tumor biology in the early 1980s, because tamoxifen became approved by the Food and Drug Administration in 1977. And so by a few years later, you start to see the impact of this very powerful endocrine systemic therapy on breast cancer survival rates. But of course, tamoxifen is only going to reduce breast cancer mortality rates among patients with estrogen receptor positive disease. As shown by the bar graphic to the right of this slide, African American women have notably higher frequencies of ER negative breast cancer. And so we simply did not benefit to the same degree as other population subsets from these wonderful advances that began to be made in managing estrogen receptor, hormone receptor positive breast cancer. We've obviously gone far beyond dichotomizing breast cancer as simply being ER positive versus ER negative, and our translational research colleagues have demonstrated to us that breast cancer is actually a very heterogeneous disease comprised of several different intrinsic subtypes, with the basal intrinsic subtype being one of the more virulent subtypes. And the triple negative breast cancers, the cancers that are negative for estrogen receptor, progesterone receptor, and HER2/neu, for the most part correlate very closely with the intrinsic basal subtype. And so we use immunohistochemistry to identify patients that are likely to have the aggressive basal subtype. It's not a perfect match, but having a triple negative breast cancer is a pretty good surrogate for identifying a patient with a basal intrinsic subtype. And as shown by the curves all the way at the top right-hand corner of this slide, we see that at every stage of breast cancer diagnosis, women with the triple negative breast cancers have a worse outcome compared to women with non-triple negative breast cancers. African American women have pretty definitively and consistently been shown to have higher frequencies of triple negative breast cancer in every age category of breast cancer diagnosis and at every stage category of diagnosis when compared to white American women. And there's been an interesting phenomenon that's occurred over the past several years where the population-based breast cancer incidence rates have been rising disproportionately in Black women, so that today the incidence rates are actually pretty comparable for Black women and white women. And these rising incidences of breast cancer in Black women, coupled with the higher risk of triple negative breast cancer, has already resulted in a widening of the mortality gap. And today, breast cancer death rates are approximately 40% higher in Black women compared to white women. It's impossible to have a discussion regarding the triple negative breast cancer burden of African American women without commenting on the screening mammography debate. And as all of you are aware, the United States Preventive Services Task Force has been aggressively advocating that average risk American women delay initiation of screening mammography until they reach age 50. Those of us who focus on breast cancer disparities between Black women and white women are very concerned that if all American women adhere to the USPSTF recommendation, we will see a further widening of the mortality gap, because as shown here by the California population-based incidence rates of breast cancer, looking here not at frequencies of triple negative breast cancer, but at actual population-based incidence rates, we see that those triple negative breast cancer incidence rates are higher for Black women in their 40s, not only compared to white women in their 40s, but they're even higher than the incidence rates of triple negative breast cancer for white women in their 50s. And so if Black women delay initiation of screening mammography, it's likely to worsen outcomes by delaying a diagnosis of a biologically aggressive cancer in a population subset that is already at higher risk for getting disease at younger ages. The critics of screening mammography are always quick to point out that mammograms may not be the answer to addressing disparities because triple negative breast cancers tend to be more difficult to detect on mammogram, and because the triple negative breast cancers, as we showed earlier, have a higher mortality rate compared to non-triple negative breast cancers, even when they are detected at an early stage. But here we see very nice data from both the Memorial Sloan Kettering Group and the National Comprehensive Cancer Network that early detection of triple negative breast cancer does still make a difference. And in both of these studies, we are seeing that women diagnosed with triple negative breast cancer no larger than 1 centimeter in size and with negative nodes have an excellent outcome regardless of whether they receive adjuvant chemotherapy or not. Now, those two studies were looking at early detection of triple negative breast cancer, but they weren't necessarily looking at mammographically screen detected triple negative breast cancer. And so our group at Weill Cornell Medicine combined our triple negative breast cancer database with the triple negative breast cancer database from the Henry Ford Health System in metropolitan Detroit. And we did look specifically at outcomes from triple negative breast cancer, accounting for whether the disease was detected by screening mammography or not. And we looked at a whole bunch of different features that might be associated with outcome, as shown here for both white women and for Black women. The strongest determinant of having better overall survival from triple negative breast cancer was having that triple negative breast cancer screen detected on a mammogram. And so mammography screen detected triple negative breast cancer does make a difference when it comes to outcomes. And I would argue that it's even more important for Black women because of that higher risk of the disease at younger ages. Now, as you guys all know, women who undergo multiple breast biopsies are at higher risk for developing breast cancer in the future. And that's the reason why the Gale model, as Melissa alluded to previously, includes number of breast biopsies as a determinant of future breast cancer incidence. But by and large, women that have multiple benign breast biopsies as their risk factor for getting breast cancer in the future, they almost always get an estrogen receptor positive breast cancer. We looked at the Henry Ford Health System benign breast disease cohort to see if African American women with a benign breast biopsy history still had a higher risk of triple negative disease, which would suggest that there's something inherently different about the mammary tissue of Black women. So we had more than 6,000 women in this benign breast disease cohort with more than 10 years of follow-up, and we had evidence of equitable management of these patients with benign breast disease because there were equal rates of subsequent breast cancer development in the Black women and the white women. And for the women that did get breast cancer, the stage distribution was comparable. However, when we look specifically at the incidence of triple-negative breast cancer, those incidence rates were nearly 4 times higher in the Black women, suggesting that there is something inherently different about the mammary tissue of Black women predisposing us for this biologically aggressive tumor phenotype. So several investigators have tried to answer the question of whether disparities in breast cancer outcomes and breast cancer survival rates will persist after you stratify for tumor phenotype. And I won't belabor this slide, but suffice it to say that a recurring theme is that when you look at women with triple-negative breast cancer, as long as you account for stage of diagnosis and treatment, the Black women and the white women often have equal outcomes. When you look, however, at women with estrogen receptor positive disease, several studies have continued to show a survival disadvantage among the African American women with a biologically more indolent cancer. Whether or not these differences are related to differences in response to endocrine therapy or differences in primary tumor biology, or just differences in compliance with the many years that are recommended for endocrine therapy, those are questions that still warrant research in order to answer them definitively. The TAILOR-X study sought to investigate that question a bit more vigorously. And as you guys are aware, the TAILOR-X study looked at nearly 10,000 women with hormone receptor positive, HER2 negative, and lymph node negative breast cancer. And the study was designed to look at whether women with an intermediate oncotype recurrence score would benefit from adjuvant chemotherapy or not. But they also did a planned subset analysis looking at outcomes for women with this tumor phenotype based upon whether the women were Black or white. And they indeed found that the Black women with these intermediate risk 21 gene recurrence scores had significantly higher risks of recurrence and risk of death, suggesting that for women with hormone receptor positive disease, there's something biologically more aggressive about the tumors in Black women. Others have utilized the Cancer Genome Atlas data to try to address whether or not there is different tumor biology or genomics in Black women compared to white women with breast cancer. And TCGA, of course, is looking at pretty much the same 700 plus white American women that have contributed data compared to the nearly 170 Black women that have contributed data to date. And so it's not surprising that the different investigators that have used TCGA to evaluate disparities have identified similar themes in their various studies. PAM50 analyses from TCGA confirm that African American breast cancer patients are more likely to have the intrinsic basal subtype and less likely to have the luminal A tumors compared to white American women. And the tumors of Black women are more likely to have P53 mutations and less likely to have PIK3CA mutations, which goes along with the ER negative versus ER positive patterns of disease in Black women compared to white women. This theme of having higher rates of ER negative and triple negative breast cancers among women with African ancestry is actually not something that is unique to the United States. And as summarized on this slide, studies from the Great Britain, studies from Brazil, and also studies from Switzerland have all reported that the African ancestry breast cancer population subsets in those countries are more likely to have ER negative and triple negative breast cancer compared to the non-African ancestry breast cancer patients. And so these types of data have motivated my research group, the International Center for the Study of Breast Cancer Subtypes, and the international research groups of other teams to look at the breast cancer burden of women residing on the continent of Africa to see if we can tease out some of the germline genetic markers associated with African ancestry that might also be associated with risk of triple-negative breast cancer, which is an extremely important question because to date, we really know very little about the causes of triple-negative breast cancer. And so we are excited that these types of global research efforts will not only teach us more about breast cancer disparities domestically, but it might also give us some unique insights regarding the pathogenesis of triple-negative tumors. To summarize what we've seen in our international work thus far, I'll summarize the data from this bar graphic. Women residing on the Western Sub-Saharan region of Ghana, a region of Africa, as represented by Ghanaian women shown on this slide, have very high frequencies of triple-negative breast cancer in our research. About half of the Ghanaian breast cancer patients have triple-negative tumors, compared to only 15% of Ethiopian women representing East Africans having triple-negative breast cancers. And approximately 29% of African-American women have triple-negative breast cancers, which is intermediate between the frequencies that we see in Ghanaian women and the frequencies that we see in white American women. Studies from the SEER registry have paralleled our international studies. And in the SEER registry, Dr. Jamal has looked at frequency of estrogen receptor negative tumors, which of course is a subset of triple negative breast cancers. And what they've shown from SEER data is that not only do African American women have higher frequencies of ER negative tumors compared to white American women, but women born in West Africa, but who get their breast cancers here in the United States, also have higher frequencies of ER negative tumors. And women born in East Africa, but who get their cancers diagnosed here in the United States, have notably lower frequencies of ER negative breast cancers. And so this is why we have coined the nomenclature of oncologic anthropology to try to explain these patterns. If you look back at the transatlantic slave trade that occurred in the colonial era of America's history, we know that the ancestors of contemporary Western Sub-Saharan Africans, including contemporary Ghanaians, were the Africans that were brought across the Atlantic Ocean to serve as slaves in the Americas. And so as African Americans, we have quite a bit of shared ancestry with contemporary Ghanaians. The slave trade from East Africa, on the other hand, largely brought the ancestors of East Africans, including contemporary Ethiopians, further eastward to the Mideast and to Asia. And so as African Americans, we tend to not have quite so much shared ancestry with contemporary East Africans. And so if there is something linked to the germline genetics of African ancestry, increasing susceptibility for triple negative tumors, it's probably specifically related to Western Sub-Saharan African ancestry. I and some of my translational research colleagues, such as John Carpton, shown on this slide, have therefore been very vocal in suggesting that the oncology research community really needs to go beyond simple self-reporting of racial ethnic identity when we are looking at differences in cancer outcomes. Self-reported identity is still valid and very important, because again, racial ethnic identity to some extent is a socio-political construct. However, we need to understand more about the germline genetics of racial ethnic identity as well when we try to understand cancer outcome differences. So our group, the International Center for the Study of Breast Cancer Subtypes, was extremely excited about 5 years ago when we were able to successfully recruit one of John Carpton's mentees, the brilliant geneticist, Dr. Melissa Davis, to serve as scientific director of our team. Melissa, for most of her career, has been an expert in studying a particular gene known as the Duffy gene, or the Duffy antigen receptor for chemokines. And this is a very interesting gene to look at when it comes to health outcome disparities related to racial identity, because there's a specific allele, a specific variant in the Duffy gene that is almost exclusively seen in individuals that have Western sub-Saharan African ancestry. And that variant is known as the Duffy null variant. Now, Melissa's been studying this Duffy null variant for most of her career. Other investigators have kind of happened along the Duffy null variant in their studies of breast cancer disparities. Here I'm showing you data from the AMBER Consortium, where the investigators were looking at differences in circulating chemokine levels among Black women and white women that did not yet have a diagnosis of cancer, but they wanted to see if some potentially cancer-associated circulating chemokines differed between Black women and white women. They did identify a handful of chemokines that were different for the Black women compared to white women. And then when they went on to perform genotyping, they found that the Duffy null variant was the variant that seemed to account for these differences. Other investigators have found that the Duffy null variant is associated with a benign condition called ethnic neutropenia, where African Americans tend to have a lower average white blood cell count compared to whites, but this doesn't carry clinical significance. It's a numeric observation. And others have been looking at the Duffy null variant in prostate cancer and in transplant rejection patterns. Unfortunately, however, when it comes to cancer work, many of the genetic and genomic studies and many of the genome-wide association studies have focused on populations of patients that do not have African ancestry, as shown by these pie diagrams. And so variants that are linked to African ancestry, such as Duffy null, will pretty much be overlooked in those analyses. So we were very excited to have Melissa conduct some studies of Duffy null in our quite large biorepository. And this is simply a snapshot of the patients that she looked at a couple of years ago, again, showing that this biorepository demonstrates notably higher frequencies of triple negative tumors in the African American patients and the Ghanaian patients compared to Ethiopians and white Americans. So we looked at several different genetic variants that have been reported to possibly be associated with breast cancer and triple negative breast cancer risk in the literature. And we forced into the analysis looking at the Duffy null variant. And thanks to the brilliant biostatistical work of our colleague from Henry Ford, Dr. Yale Chen, in conducting all of these analyses, we found that the Duffy null variant was actually the strongest predictor of having a triple negative breast cancer compared to having a non-triple negative breast cancer. And this was seen regardless of whether you looked at the dominant model or looking at simply the presence of the Duffy null as either of the two alleles in the genome. The brilliant work of the anthropologist, Dr. Sarah Tishkoff, has shown us that many of the so-called ancestry informative markers that we evaluate in trying to determine our genetic ancestry, these ancestry informative markers are not random events that are developing in the human genome. Many of them actually reflect locally adaptive traits, and they reflect changes related to selection pressure on the human genome, allowing populations in different parts of the world to survive different environmental threats, such as the altitude or climate, infectious diseases, or even food sources. And Duffy null is one other example of this type of an event. The Duffy null variant is extremely common in individuals that have Western sub-Saharan African ancestry, because Duffy null is one of the variants that was acquired by the human genome many, many thousands of years ago. in developing resistance to malaria. And malaria became endemic in Western Sub-Saharan Africa probably 10 to 12,000 years ago because of the many lowland and watery, low altitude areas of that part of the continent, which support the mosquito life cycle. And the mosquito, of course, is the carrier for the malaria parasites. And so since malaria is such a deadly disease, variants such as Duffy null and sickle cell were acquired over the generations and are seen abundantly in subsequent generations, regardless of where those generations reside in the world. Now, Duffy null has a different history in parts of Africa where there are a lot of mountainous highland areas, such as in East Africa and Southern Africa. And those areas do not support the mosquito life cycle to the same degree. But about 5,000 to 6,000 years ago, something occurred called the Bantu expansion, where Western Sub-Saharan Africans migrated across the continent. And so today you do see varying degrees of genetic admixture between Western Sub-Saharan Africans and indigenous East Africans and South Africans. And so you see varying degrees of the Duffy null variant in different parts of Africa. And a map of the frequency of Duffy null in Africa correlates very, very closely with frequencies of triple negative breast cancer in different parts of Africa. The Duffy null variant came across the Atlantic Ocean during the colonial era slave trade. And because we have a lot of genetic admixture with Europeans among African Americans today, we see the Duffy null frequency not at the same 100% that we see in Western Sub-Saharan Africans, but due to admixture, we see it in close to 3/4 of African Americans. The reason why Duffy null confers some protection to malaria is because if you have the Duffy null variant, then you lack the Duffy protein on your red blood cells. And the Duffy protein is actually a portal of entry for the malaria parasite to get into the red blood cell and cause the disease. Today, we are learning, however, that if you lack that Duffy protein on your red blood cell, you also lose some of the buffering capacity that the red blood cell provides for certain circulating chemokines. And we think that this is what accounts for the patterns demonstrated by the AMBER Consortium investigators that I showed you previously. Ongoing work in Melissa's laboratory is seeking to connect the dots between the Duffy null variant, Duffy protein expression, and the mammary inflammatory immune landscape and microenvironment, accounting for the subsequent risk of developing a triple negative breast cancer. The work that Melissa's laboratory group has done using TCGA has demonstrated that having lower expression of Duffy in breast tumors is more common in African American breast cancer patients, and lower expression of Duffy in tumors is associated with worse outcomes across the different phenotypes. And this may account for the observation of African American women having worse outcomes compared to white American women when we look specifically at hormone receptor positive breast cancer. But again, a lot more detailed work needs to be done to connect these dots definitively. So we have indeed been very excited about our international collaborations to learn more about breast cancer disparities from a biologic perspective and genetic perspective, but it's also been a wonderful opportunity to invest in the capacity of delivering cancer care in countries that are woefully under-resourced when it comes to cancer supplies. And our mission for the ICS-BCS is to reduce the global breast cancer burden through advances in research and through delivery of care to diverse populations worldwide. And we've been able to do this by establishing immunohistochemistry programs in our partnering facilities so that they are able to define whether or not their patients have an ER positive, ER negative, or triple negative tumors. We take these evaluations for granted here in the United States, but in most hospitals in Africa, patients simply do not even have this information available to them. We've been able to establish core needle biopsy programs so that they can make their diagnoses more efficiently. And of course, the pace of our telemedicine communications has been accelerated through the COVID pandemic. And we look forward to returning to our usual 2 to 3 time yearly visits. And this August, we will be going back to Ghana for the first time since the COVID pandemic hit in 2020. So now that our international team is headquartered here at Weill Cornell in New York, we're very excited about conducting parallel studies looking at the robustly diverse patient population of the Triborough region of New York that we serve. And we have our breast cancer campuses in Manhattan, in Brooklyn, and in Queens. And the diversity of these communities is shown by the bar graphics on the right of this slide. I'm going to skip over some of these slides in the interest of time, but we have indeed been very excited about conducting deeper dive studies into the germline genetics of African ancestry. And we've been learning some very provocative things regarding the diversity of that germline genetics. And a lot of the work that we do is now linked to the Weill Cornell Medicine Englander Institute of Precision Medicine, which has allowed us to actually create organoid models from some of our tumor samples from Ghana. And there are other examples of germline genetic ancestry impacting health. The apolipoprotein L1 protein is a variant that has been linked to African Americans having worse kidney disease. And the particular variant of ApoL1 is an African ancestry variant that was developed because it conferred some resistance to the African sleeping sickness. My brilliant colleague, Dr. Laura Federman, and colleagues from the West Coast has done some exciting work looking at how admixed Latinx women are at higher or lower risk of getting breast cancer, depending on the extent of their European germline genetic ancestry compared to the extent of their Native American ancestry. And they've documented that extent of European ancestry increases breast cancer risk, whereas higher Indigenous American ancestry seems to reduce breast cancer risk. And whenever I talk about breast cancer survival rates and disparities, I always include these 3 survival rates of 60%, 43%, and 20%, which have nothing to do with cancer outcomes, but these reflect the survival rates of the first class, second class, and third class cabin passengers of the Titanic. And I quote these survival rates because even though our own research is very much rooted in studying the germline genetics of African ancestry and how these genetics contribute to breast cancer risk, we always have to come back to the fact that outcome from any threat to life is going to depend on access to care. And just as the third class cabin passengers of the Titanic did not have equitable access to the lifeboats, it remains true that our communities of color do not have access to optimal cancer care. And this is a tragedy that we absolutely have to address. And as stated by the Reverend Dr. Martin Luther King Jr., of all the forms of inequality, injustice in health is the most shocking and inhumane. And we saw this play out recently with the COVID pandemic, where COVID-19 morbidity and mortality is now added to the long list of diseases that are disproportionately severe in the African American population. Ned Sharpless has wisely and sadly projected that as a consequence of the COVID pandemic and its impact on screening, its impact on cancer research, we're likely to see an excess 10,000 deaths from breast and colorectal cancer before this decade is over. Because the COVID recession has been disproportionately severe on communities of color, we can predict that communities of color are likely to experience the greater burden disproportionately of those excess deaths But I do believe that if we work together collaboratively and intentionally, we can mitigate this possibility. We need to address the healthcare access issues. We need to support our safety net hospitals, which were disproportionately devastated by the costs of COVID care. And these same safety net hospitals provide cancer screening and cancer care to many of our communities of color. We have to support our advocacy and philanthropic partners, which had their community outreach programs impacted adversely by the COVID pandemic. And we also have to lean on our hospital leadership very strongly. I continue to be very fearful that as our hospitals try to balance their budget, they will see navigation programs and outreach services as being the low-hanging fruit when they're trying to cut costs. So we have to make sure that those programs are protected. We also have to address the digital divide, which we've all become so much more reliant on in the wake of COVID. And unfortunately, it remains true that African-American households are significantly less likely to have broadband internet, high-speed internet access compared to white American households. And in closing, I just want to thank all of the wonderful organizations that have supported our research over the years. And our research I do dedicate to my sister, Debbie Newman, who tragically became another victim of triple-negative breast cancer very, very recently. And just barely a couple of months ago, my brilliant and gorgeous sister was afflicted quite suddenly with an extremely aggressive form of triple-negative breast cancer that manifested itself de novo as symptomatic brain metastases. And she succumbed to the disease 3 months later. So this fight, all of this work is extremely personal for me now. So I close there, and I do thank all of you for your time and attention.
Lisa, that was the most brilliant talk, and thank you for taking us through this ride of the history of breast cancer disparities through your work in Africa. And the last time I saw you, you told me about your sister, and I just feel for what you've gone through and what you're going through of taking care of your family and her son. And I understand exactly how that's it's your motivation now to continue what you're doing, and I get it. And you being a breast cancer surgeon, I'm sure it was just flabbergasted to have to see what your sister went through and not having the chance to even deal with her having treatment. So I understand that. I'll ask a question because, you know, the last part of your talk about the disparities and things that we're going to have to take care of, especially with COVID, is really is going to be an eye-opener for all of us to have to, especially our centers, which are here in fairly wealthy areas in the of having our catchment area and not so wealthy areas of having to deal with these things. So I'm glad you brought those points up because we have to be reminded of that all the time. But the question I have is going back to the science and, you know, the work that you've done with the Duffy null and all of those things. Have you combined any of that when I saw that you were looking at the germline genetics of any founder mutations, because you brought that up at the very end. And I'm wondering, as you start combining these things and bringing up Lara's work and some of the other things with some of the founder mutations, it will be really interesting to see how, you know, combining even more of the data together to see if you really can start to identify subsets of individuals and really understand some of the genetics. It's really fascinating. Thank you. And I'm going to let you answer that and look in the chat to see what questions we have. And people can raise their hand if they have, and Maria can help me call on all of you. Allison said hi, so did Irene, and truly outstanding work. People have said Irene Wapner and others. So I'd like for people to ask questions, and maybe you can answer that one, and then we can call on people from the audience.
But I think, as always, you're spot on in your comment, Melissa. I do believe that these germline genetic studies will end up having some ties to BRCA as more and more African-American families get tested. As you know, we are seeing higher frequencies of definite BRCA mutations. The Florida group has already identified some BRCA founder mutations related to Afro-Caribbean background. And I'm very excited about seeing more Black families getting tested, because the past patterns that we were seeing, which is getting better now, now that we are seeing more families getting tested, but historically we were seeing so many more variants of uncertain significance in Black families simply because we didn't have enough data on these variants. And some of these VUSs probably do carry some significance, but yet these patients were not able to avail themselves of PARP inhibitor therapy because we just don't use it in patients that have VUSs. So these types of genetic analyses really are critical to cancer treatment and outcomes.
And even the comparison with what you're seeing in Africa is going to be really important, I think, too, with especially when you show the anthropological change, movement from slavery and people moving to the United States. It's so fascinating. Thank you so much for your brilliant talk. Candace Thompson has a question here. Thank you for your amazing talk regarding the Duffy antigen receptor in breast cancer. Are you or your colleagues currently collecting tissue or enrolling patients from other institutions to help with this work?
Yeah. We love collaborative Sure, absolutely, absolutely. And as Melissa mentioned at the beginning, we are extremely excited about having established other partners in different regions of Africa, because as you said, Melissa, looking at the African diaspora and population migration patterns, I'm sure that we will identify other variants that have an impact on cancer. And since over the millennia, African populations have been subjected to so much evolutionary selection pressure because of different infectious diseases, and there is likely to be a very distinct inflammatory milieu that's associated with cancer risk. Here in the United States, we've mainly been relying upon partners in institutions where we've been based. And so some of our specimens represent University of Michigan, where we started. Others represent the robustly diverse patient population of metropolitan Detroit from Henry Ford. And now, of course, we have many, many hundreds of specimens from the Weill Cornell and NYP network. I'm really excited that we recently have been invited to receive funding from the Breast Cancer Research Foundation, a wonderful, wonderful organization. And I am hoping to be able to use those funds to bring the African American surgeon members of the American Society of Breast Surgeons together to contribute to our own network of Black surgeons, creating a biobank that will be housed here at NYP with our ICS, BCS. And since that is a national organization, that will reflect specimens from across the country. But yeah, we love collaborative opportunities.
Are there other questions? Elise Adams, wonderful talk, very interesting. We are just about at the hour, Lisa, and I can't thank you enough, and I just wish you were here in person.
Oh, me too. Well, I'll hopefully see you soon at another meeting.
I hope so too, and thank you so much.
To Africa with us.
I'd love to. I really would. That would be great fun.
Awesome. Yeah.
So if any last questions that anybody has before we close out. Lisa, again, thank you so much, and I know I'll see you soon.
Sounds good.
Okay, great.
Have a great day, everybody.
You too. Great day. Thanks, everyone.